A very warm welcome to the panel session, How to Achieve a Global Health Data Space. My name is Petra Ritter. I am professor for brain simulation at the Charité and the Berlin Institute of Health. And it is my great pleasure to welcome our panelists. And first, please a big applause for Dr. Steve McFeely, Data Analytics Director of the World Health Organization. Next, Dr. Marlies Dorlöchter, Head of Division of International Health Research at the German Aerospace Center. Next, Dr. Mehdi Snine, Interim CEO at the International Digital Health and Artificial Intelligence Research Collaborative, I-DAIR. And Dr. Ruxandra Dragia-Akli, Head of Global Health and Global Public Health Research and Development at Johnson & Johnson. And Pavel Sviboda, Director General of the Human Brain Project and CEO of eBrains. Thank you all for joining us here. Before we start with a heated discussion on the big question that we are posing here, I would like to give you a short introduction in the topic. So human health data, they are sensitive data. Making them available publicly brings a big risk for the data subject or the patient. And what you see here is, for example, a digital twin of a human brain. And such data, they contain very personal information. You can infer features of the personality, of the behavior of the data subject, or demographic features. So for example, from those data, you could infer for the subject behind the data, what is the degree of intelligence? Yeah? What is the ability to sustain attention over longer periods? Even what is the satisfaction of that person with their own life? And this is very personal information. It can be abused, and therefore it needs to be protected. There are different ways of protecting such sensitive health data, and one very well-known way is anonymization. But what does it mean to anonymize data? It means that all the individual unique features are removed from the data. But it is exactly the set of unique individual features that is relevant for precision medicine and for personalized health research. And therefore, anonymization very often is not a possibility. So the data stay personal. You can do pseudonymization. That means that the names, the birth dates, and the address are being removed. But the biometric information, so what you see here, the activity in the brain, for example, or the detailed structural connectomes, this is like a fingerprint and enables re-identification of the data subject and the potential abuse. So therefore, health data need to be well protected. The degree how such health data are being protected and the regulations differ regionally across the world. And also the definitions of terms like anonymization and pseudonymization, but also the frameworks, the ethical and the moral frameworks that often are the basis for the legal regulations. So in order to achieve a global health data space, it is important to first get awareness of these differences across the world and then get a certain degree of alignment. So for example, in Europe, we have the general data protection regulations in place. And interestingly, there is no ownership of personal or health data in Europe. So the personal data and health data do not fall under property rights. They are only regulated through the general data protection regulations. And these see other roles than owners or ownership. They define the role of the data subjects. This is the person to whom the data belong. The data controller, this is the responsible person that determines the purpose of the processing and also the means of the processing, and the processor who acts on behalf of a data controller. Innovators or academic researchers, they usually have the role of the responsible controller. This means they have in Europe the responsibility to protect the privacy of the data subject or the patient. And to make the life and the work of these academic researchers or also industry innovators easier, we need to support them in the complex organizational requirements. So for example, they need patient consents, they need sharing agreements, they need processing agreements, service agreements with infrastructure or service, cloud service provider, for example, data protection impact assessments, or the vote of an ethics committee. So this is a lot of work and very complex, and we need to support researchers in the academic and industrial sector to get through all this. But in addition, we also need to offer researchers and innovators trustable research infrastructure where they can do complex simulations or analysis of such very sensitive health data. Another requirement is federation of data. Yeah, we need interoperable, technically, legally, but also semantically interoperable ecosystems of data platforms or data centers. And I want to give you an example of what we are developing in the eBrains project, the eBrains Health Data Cloud, where we build such a federated system of trustable platforms. So we have, for example, a central platform, and we have the data center at the Charité, my institution, where we have already service for sensitive data. And these central platforms from eBrains and the data center at the Charité, they become interoperable. They understand each other. It's possible to send metadata, so information about the data from one center to the other center. And we have other platforms in this ecosystem, for example, at the Oslo University Hospital, at the ETH Zurich, and we are also developing interoperability with supercomputing centers in Jülich, in Barcelona, or in Stockholm. And we need to scale up these interoperable platforms in order to achieve a global health data space. If we have such a trustable infrastructure available, then we have the advantage that we can integrate information from multiple sources. I see that my slide disappeared. Can you please bring it back? So what you would see here now is a digital twin of a brain again. And you see that the simulation, okay, I go there again, is a result of the integration of multiple data sources. Yeah, so you see the data of the individual patient. In this case, it's a Parkinson patient. And you see information that is integrated from digital atlases coming from eBrains. And together you can run very detailed simulations and do in silico planning of therapeutic interventions. In this case, that would be a multi-scale model of deep brain stimulation in a Parkinson's patient. I also want to bring a couple of examples of projects that are funded in Europe. So Europe already puts a lot of resources in the development of a European health data space and of this interoperable ecosystem of infrastructures. One such funding scheme is provided via the European Open Science Cloud. And the projects that you see here are projects led by my institution, Charité. So in the EOSC scheme, this would be the Virtual Brain Cloud. Then we have the eBrains Human Brain Project projects, the Health Data Cloud. And in Horizon Europe, we have the recently started eBrain Health project. A latest addition is a project funded by Digital Europe program, the Testing and Experimentation Facilities Health AI and Europe. The interesting part of this project is that it builds a bridge to the industry. So the goal is to really close the gap in the innovation chain and to bring the academic innovations, the academic research results to the market and with this to the patient. Key players in this project are also eBrains and the European Health Data Space. The European Health Data Space has the goal to provide to the data subject, to the patient, full control of their health data. Because who else would be more the legitimate controller of their personal data than the data subjects or the patients themselves? But on the other hand, it also aims to facilitate access to academic and industrial researchers to such sensitive health data for secondary data use. And I think these goals are really great. And now I'm very curious to hear the perspectives of our panelists on the topic, how to achieve a global health data space. And our first panelist who will share her opinion with us is Dr. Marlies Dollester.
Okay, this microphone? Should I take this one? Okay, thank you. Thank you very much. Good morning, ladies and gentlemen. Thank you for attending this session at such an early hour. Thank you, Petra Ritter, for inviting me here. I think I'm kind of an outsider. I will not talk about data, but you will see that it's still related to data, to the global health data space. I will introduce to you the ARANET neuron. When I read the introduction sentence to this panel session, breaking the data silos is essential to reshape the future of healthcare and crisis preparedness, I said, yes, of course. But then the question came up, do we really have those data that are full of good, excellent, and useful data? Or do we need as society, and do we need as funding organizations, as funders and ministries, promote the generation of high quality research data? I would like to take you a few steps back, not talking about data, but to the time point when data are not even generated. What can funders do to fund the best research projects that would in turn create the best possible data that would in turn be stored, not in silos, of course, but in a global health data space? I would like to introduce to you the ARANET neuron. I coordinate this ARANET on behalf of the German Federal Ministry of Education and Research, and it is a network of funders, of funding organizations, ministries, research councils, foundations, and project management agencies. Over the past 15 years, we've been working together and together with the European Commission to support translational, disease-related brain research. And there are two central pillars, from our view, to create a European global data space. One is our joint transnational calls for proposals, our funding program. The topics of our joint calls are based on a common research agenda that aligns the national research strategies in all the participating countries and funding organizations. We fund every year around 10 to 15 projects and consortia that consists of a number of principal investigators from these neuron countries. And these principal investigators work together, jointly pursue their projects, and jointly generate data. We, as a funding program, strive to have high quality standards for evaluation and funding. And the second pillar that we think will support global data space is capacity building and training. We offer to the research community and for patients and the general public a program, methods, workshops, webinars, and training programs. Now, how do we know that we select from 150 or so submitted project proposals the best 10 to 15? We have a threefold review of the applications. The first is a scientific peer review, more like standard, and the peer reviewers judge the excellence, impact of project ideas and the quality and efficiency of their implementation. Of course, this includes the soundness of the statistical approaches and the quality of data that are proposed in general. In addition, we have an ethical review that judges the conduction of human and animal studies in the proposed projects, and also the consistency of the work program with the data management plan that we ask for. This includes adherence to the FAIR principles, to the support of open science, and responsible research and innovation principles. And in addition, we have a patient review. We invite patients to assess the feasibility and the relevance of the human studies in the projects. Are they relevant for patients and the society? And do patients act only as subjects in studies, or are they asked to collaborate with the design or do the project leaders collaborate with patient organizations? We think that our neuron applicants are entitled to a fair and transparent selection process. We have a number of reviewers from different angles that look at the applications. We thoroughly check the conflicts of interest within the review panel, and we see that there is a gender balance. And we think that our applicants need to know everything that's been written about them. We send all reviews to the applicants as feedback so that they understand why they have been selected for funding or why they have been rejected. And then maybe next time they can improve their applications. Once we have selected the projects for funding, we monitor their research quality and the data management. We ask for management plans of them, of the neuron-funded projects, because we want to implement the FAIR principles and support open science and responsible research and innovation, because we want to comply with the Horizon 2020 and Horizon Europe criteria, and of course of the legislation in our participating neuron countries. And because we feel that we need to support transparency on the investments of public funding. We ask for consortium agreements because we think it's important to align and to balance the interests of all participating researchers in the transnational corporations. And because we think it's important to take care of intellectual property rights of the results and data. And of course, we have annual reports and final reports and midterm evaluation to monitor the progress and excellence of the projects, but also to offer support if something goes wrong and if there are hurdles that we can help with. Does this all pay off? We think yes. We've been funding so far around 180 transnational projects with around 800 research groups involved. And we will have been able to analyze around half of them that are already finished. And we see that the output is quite impressive. More than 1,100 peer-reviewed publications came out of these 80 projects. We particularly like those with joint authorships because then we can see that a real collaboration has been taken place. And we are impressed by the high number of publications in high and prestigious impact journals. Of course, we have other outcomes, also patent, software development, startups, and so on. Now, as for capacity building, we offer interactive training to our running projects, to the principal investigators, but also to the young scientists in these projects, because we want to raise awareness of the researchers on issues of experimental design, of the project conduction and reporting. Some of the topics are translational validity of experimental models, data sharing, public and patient involvement in the projects. We work together with the European biomedical research infrastructures, and together with them, we produce webinars about the use of these infrastructures as potent resources for researchers. And we tell the research community how to best use available tools, for instance, for data management plans. And we have an entire program for patients and the general public, because we think that although legally patients are not owners of their data, they're still very important. They are the ones who are giving us the data, and we need to involve them in all aspects of research. We have lay lecture series, we have patient reviewer training. If you invite patients to a review training, they don't know how to do it, and we teach them how to do this and to give us the best possible input. We have video clips from young researchers and on important topics. I've shown you an overview on our hands-on activities, how we as an ARANET Neuron create or support creating a global research data space. We think that thorough and transparent funding of excellent research projects is absolutely needed. And we need an open attitude within the research community too, and within the patient and public. Brain health gains public importance worldwide. During the pandemic crisis, the incidence of mental health problems increased very, very rapidly. Fortunately, new digital technologies allow better understanding of the brain and its diseases. They produce growing amounts of data. And in order to be able, from these amounts of data, to derive strategies for prevention and therapy, it needs collaboration among researchers, the various disciplines of researchers, but also among stakeholders and policymakers to truly create a global brain research area. And one step in this direction is made by the European Commission already. They plan a European partnership on brain health starting as of 2025, 2026. And I hope that the ARANET neuron will be part of this. Thank you very much for your attention.
Thank you very much, Dr. Marlies Dorlechter. And our next speaker is Dr. Roxandra Dragia-Akli.
Good morning, everyone. So if I may have my slides. So I am Roxandra Dragia. I am the global head for global public health research and development in Johnson & Johnson. And it is really a pleasure to speak to you today about how data sciences and digital technologies can accelerate and improve the ability to actually deliver health for all. Let's see. Okay, we have it. So COVID-19 really brought to light many inequalities within our healthcare systems, but perhaps most clearly is the digital divide. So globally, we see too often that the benefits of digital health trickle down to communities rather than start with the intention of innovation for those most underserved who live with the greatest burden of disease. And as a consequence, us in global public health R&D in Johnson & Johnson have made really pivotal investments in expanding our integrated technology and data sciences capabilities to achieve two key objectives. First, to reduce the burden of disease through effective, customized, and inclusive disease-agnostic platforms, and really doing that by partnering with implementing organizations in treatment as well as prevention needs, from adherence to diagnostics, to data management, to surveillance in resource-limited settings. So our vision is truly to scale up a suite of inclusive, locally sustainable, integrated digital intervention solutions and data sciences analytics to facilitate health equity and access in resource-limited settings. So our portfolio, as you see, is rapidly expanding into growing health threats like dengue, pandemic preparedness and response, to clinical trials, to emerging pathogens and outbreak forecast. So how do we do that? It is really meant to be an structured effort to really unlock the power of data sciences and technology at every step of patient journey. So we are trying to start by developing cost sensitive, and I really underline the cost sensitive. We are actually addressing the needs of resource limited settings, digital solutions to really influence outcomes and generate insights while considering interoperability, sustainability in very early stages of design. So typically, we work with data standards and libraries that can be readily linked with the systems used by authorities in these low and middle income countries. And we are operating while supporting local analytics and really skilled, trained personnel that can learn new data skills and work on their own sets of data. So I'd like to share, out of all that list there on the slide, 3 examples from our portfolio that are generating data that is really strengthening regional disease management programs through this collaboration and partnership at the country level. So for those who were in the Ebola session yesterday, you've heard about our digital platform, Vaccinate, but now I'm going to give a little bit of a history of what that platform entails and how it came about. It is really a digital platform that integrates innovative technologies to improve patient tracing, actually is really healthy individuals that are coming to be vaccinated, data management and communication technologies to implement vaccination campaigns in low resource settings. So the platform has 3 main pillars. It's starting with person identification capabilities, then a dashboard reporting, and then an engagement capability. The need for this platform was born from a program that originated in an innovative medicine initiative program called EBODAC. And really, it was meant to first address the challenges of identifying individuals that are coming to vaccination. I'm talking about a vaccine that entails 2 doses, a heterologous prime boost that need to be given 56 days apart. So you give the prime and then 56 days later, a boost. You needed to make sure that you are vaccinating in the right order, the right person at the right time in geographically extremely challenging circumstances and in an Ebola outbreak. So, the classical identification methodologies in those countries, which is like fingerprinting, was really not something that we really wanted to apply, nor the little identification cards that sometimes, pieces of paper saying, you need to come back to a vaccination 56 days later, which were very inefficacious. So we've decided to really use a biometric identification and actually settled on iris scanning to avoid, the fingerprint in an Ebola outbreak. So that was the first step. The second step is really from identification to a real-time operational and program level reporting. So we wanted to make sure that the country managers had the perspective of where are the vaccinees, where are the sites, how many vaccines have been used at every single one of those sites. So obviously for a vaccine dose management purposes, and to really have this support for operational insight close to real time. Actually, you had this reporting every day that can follow the campaigns. Reports go from very high-level aggregated data views down to health center level information. And those insights actually enable data-driven decisions to be taken in terms of the operational organization, like the management of stock, as I've mentioned, or staffing resources. The final component of the platform provides engagement capabilities. So as we've discussed yesterday in the Ebola session, in these circumstances, there is a lot of misinformation that is circulating. Plus, the individuals had to be recalled for their second vaccination. So we've designed together with our collaborators a mobile technology where messaging in the language in the country could be delivered either calling back the individuals for their second vaccination, or providing information about the campaign. COVID happened in the middle of our large vaccination campaign in Rwanda. We were meant to vaccinate 200,000 individuals. There was a volcano erupting, and with all those elements, we needed to make sure that the individuals that had received the first dose of vaccine were able to come back in time for their second dose. And despite all these complexities, using this text and voice messaging, we were able to achieve before COVID-19 compliance rates of 99%. And during COVID-19, compliance rates of 93, 94%, which was extraordinary for this type of vaccination. Next, what if we can actually predict outbreaks before they occur? And our team is actually working on such technologies. We are leveraging artificial intelligence and Google Analytics to create models to forecast, for instance, dengue outbreaks and support clinical trial development. So, for instance, in our phase 2 prophylactic clinical trial for a dengue small molecule antiviral, we are using this technology to accelerate site insourcing and recruitment. And it is really, really important to know where and when dengue hotspots are likely to occur. And our team has designed a near real-time dengue case data tracking tool based on data from different government reports from 10 countries, 6 in Latin America and 4 in Southeast Asia, which is very suitable at the level of granularity and both spatial and temporal. So to forecast short to midterm dengue cases, a collection of individual models and Ansible approaches were evaluated, and longer term evaluations up to 1 year ahead are made using weather, climate data, pattern of intermediate host, which is the mosquito, et cetera, et cetera. So we actually found that the short to midterm models outperform the baseline models that carry the current case counts forward to the next month. So our tool can predict with about 85% accuracy 8 weeks ahead where a hotspot of emergence of dengue would occur. So it has been this particular tool made available to local governments, and that is enriching the set of data. Finally, I would like to share how data sciences are strengthening our biomarkers and diagnostic efforts across multiple disease areas. So we are not the Googles of the world, and we are not the Apples of the world, and we don't have fancy programs. We really underpin our research programs with our platforms. So we have undertaken a tremendous amount of work to identify new biomarkers when it comes to dengue, to antimicrobial resistance, tuberculosis, and even imaging biomarkers for leprosy. So from clinical trial to forecasting and clinical development, we believe that data science and technologies can play a critical role in bridging gaps, both in collaboration and in health equity. So our real hope is that integrated data and collaboration around a spectrum of R&D activities can contribute towards a global data space that is inclusive, both in terms of data and in terms of gains for those that actually can benefit from it. Thank you, and I'm looking forward to the discussion.
Thank you very much, Dr. Ruxandra Draghia-Akli. And our next speaker is Dr. Steve McFeely, please.
Good morning, everybody. My name is Steve McFeely. I'm the director of the new Data and Analytics Unit at the World Health Organization. So this morning, I'm going to be talking about our new World Health Data Hub, which I hope will appear on the screen very shortly. So in December, all going well, we will be launching the beta version of the World Health Data Hub. So the hub, I hope, will be the platform where we can generate truly global health data products. One of the challenges, sorry, I was hoping my slides would come along. Here we are. So what we want to do, as you see here, is produce global public goods. Now, by public goods, what I mean, we're thinking broader than the economic definition of just non-rivalrous and non-excludable. We're thinking beyond just open data. What we want to do is produce public goods that are public right across the life cycle of the data. So in other words, we encompass good quality data from the start until the end. The idea of this hub is to put everything in a way that you can find it. So currently, if any of you have used the World Health website, you will know it's quite difficult to find anything. So currently we produce almost 800 or more than 850 reports. We disseminate the statistics through over 550 different portals. This makes it very difficult for the user to find the information they want, but also from a governance point of view, it makes it very difficult to manage those data. With 550 different portals, we have different data standards, we have different look and feel, we have different cybersecurity risks. And this really is very, very difficult to manage. So the challenge now is how to organize this in a way that makes it easier for the user to find the data, to use the data, but makes it easier for us to manage the quality of the data. So as I said, in December, we hope to launch a new World Health Data Hub. This will be the beta version. And the hub is more than a dissemination platform. As you know, we're a member state-driven organization. So what it'll also allow us to do through a country portal is allow us to ingest data directly from countries, but also to communicate with countries when we do country consultations. It will also standardize the metadata, the paradata, the classifications. So there'll be a lot more control as the data is ingested into the system. It will also provide a mechanism for clean data sets, allow us to model. And crucially, what it will also do is it will hold statistics and data. And I make that distinction very deliberately. So the front end will make statistics available to everybody, but we will also hold data in a data lake. These data will be World Health Organization data, but also data from academic institutions. If Johnson & Johnson, for example, would like to give us data, we'll be happy to store it there. And then the accessibility to those data will depend on the type of data and the conditions that surround those data when they were generated. And then crucially, we'll be organizing the dissemination. So there'll be a set of common tools, which will mean the look and the feel, the standards across all of the different data sets will be harmonized. So the World Health Data Hub is built on 6 stacks. So you have the country portal, which is really for member states. That's how we communicate with them. That's how we ingest data from them. We have a data lake, which is where all of the data, whether it's WHO data, member state data, or other research or academic data will be stored. The data warehouse helps us to organize those data. The data.who.int is the front end. That's the bit that you'll see as a day-to-day user if you're downloading statistics. And then there'll be a visualization engine, which will harmonize how we visualize information, but also allow you, the user, to experiment and to create your own visualizations. And then also this year, we set up a geospatial center, which is crucial for the development of WHO statistics. And that will be integrated in so that we'll start to overlay any data that we can geotag and provide geospatial information. So the idea is to make your experience better, to allow accessibility, but it also not just you, everybody in the world. So the idea is that we're really driving an open data model. So everybody in the world gets access to the same data at the same time. There'll be no privileged customers. As we develop, then we're developing one engine. That engine should be more responsive to your needs. It should provide better cybersecurity. It'll be multilingual. It'll be inclusive in the sense it'll also cater to different needs. So people who are visually impaired, people using different platforms, different data sets can be tailored to different speeds. So if broadband speeds are weaker in some areas, some products will rely less on heavy infographics. And crucially, it's shareable. The idea is to really facilitate the user to use the data that are available. One of the other things I hope in time we will do is we will be more transparent around which data are actually reported data and which data are modeled data. One of the challenges at the moment that we see as we're now importing data is it's not always clear where the data come from. The provenance isn't always evident. And my concern as the director is we're possibly papering over the cracks and making the data situation look better than it is. So in a lot of the new data sets now, it'll be accompanied by metrics on how much of these data are actually reported and how much are modeled by us or by somebody else. And that's it. Thank you.
Many thanks, Dr. Steve McFeely. And our next speaker will be Dr. Mehdi Snene.
Colleagues, I'm really happy today to bring the South voice in this big debate and long discussion regarding data sharing, being an African, but also representing an organization that mostly operates in the Global South. I got the opportunity to work with some of you previously in one of the highest challenging data sharing environment at the Human Brain Project. And currently I'm leading the International Digital and AI Research Collaborative, and we are building a research network for leveraging and enabling AI and digital research in the Global South, but also South to North. Before starting about the data sharing, I'd like to bring some feedback about my experience on the ground in the Global South regarding the data availability, and the data sharing later. So firstly, as you may see, this is the internet map that has been produced years ago, but I guess that it's 4 or 5 years ago, and represents all the connections of internet in real time during 24 hours. That gives us a quite good representation of the reality of inequality of connectivity, connections, of the access to the data, but also the access to the data generation, data harvesting, data storing, and data sharing tools. So prior to jumping into the data sharing, I'd like to emphasize this inequality between the Global South and the North. It's very clear. It's do not need a lot of advocating work there to claim and ask for more connectivities for the Global South in order to reach this universal health coverage that most of us agree that it should be done through a digitalization process, more investment in AI in healthcare research. Also, the connectivity is one of the essential pieces in the building of the roadmap towards the universal health coverage. This inequality in distributions of resources is very well reflected in our recent work at the Global Research Map within I-DAIR. We have been doing a landscape of scientific publication in digital health and AI, integrating most academic available resources. So we have been screening 25 million research papers to extract who is producing most research publications in digital health and AI. And we can see it very clearly that three countries are producing almost half of all publications in the world, with a great lead from the United States and China, and currently India, who is joining the trio of the advanced trio in publications and in the production of publications. There is very few numbers with the concrete impact. If we pick any of our African or Global South regions to see the impact, the global impact of Central Africa and West Africa in the scientific publications in the world, it's equal to 0.12% of the global amount of these publications. But not only it's very small amount of publications, most of these publications are citing African, Central and West African country, but they are much more produced in the global North than in the global South. So if you look at the authorship of these publications, we have an imbalanced attribution of the ownership of these publications, since most of the analytics and the publication effort or the funding is coming from the North rather than from the South. This scientific publications inequality has an immediate impact on the development of patent in digital health and AI and in translational research. Here, the schema is a little bit different than the in digital health publications and research, where we see that two countries that are China and the United States of America are producing at least 60% of the global number of patents in the world that are related to digital health and AI. This is an something that is very impressive in terms of the gap that is happening currently in digital health and AI research, and by consequence in the data that being produced behind these patents. So as an international organization operating in this transformation and integration of digital health and AI in the Global South, we are mostly focusing on implementation, learning health systems to drive the digital transformation within the existing health systems, to reduce the gap between the evidence and the practice, and to bring quicker results into the ground so that we can resolve some concrete and pragmatic health issues in the Global South. A learning health system is essentially composed from three elements: practice, generation of evidence, data to gather these evidence that are transformed again in the practice. And then it's a cyclic event, and then it's a cycling system that looks very similar to the digital health and AI research systems, where we have practice, we generate models, and then we train these models on data that generate new kind of practice, and it keep improving over the time. So the question of data for learning health systems, if they are implemented in silos or if they are implemented in a collaborative way, what we can implement through the learning health system is an organizational memory within the healthcare system that can improve over the time. But if we proceed to a siloed approach for the learning health system again, then we will end up with a different silo of healthcare systems that are implemented across different healthcare providers or countries that do not interact, and then they do not share mutual knowledge or mutual data. We have seen that if you bring more data, if you pull more data, and then we can overcome quicker to some current issues, we can produce better evidence, and we can translate these evidence very quickly to the practice. The problem is, how can we mutualize these data together in the same system? So before talking about data sharing, especially when it comes to the Global South, we need to talk about the fairness of sharing. So we have seen a lot of projects and pilot projects running in the Global South, at least in the countries where we are operating, but not all of these pilots are quite linked to the centric or the context of these countries. So if you give the example of mental health research, we have been asking from many African countries and Global South countries to provide data regarding mental health and well-being. While the questions and the concern and the conditions of mental health in Global North and Global South are quite different, most of the data requests are linked to some clear requirement coming from the Global North rather than from the Global South. Secondly, we are at the fairness of sharing, we are at the heart of a big problem. We are mostly funding equipment for data collections and rarely investing in data analytics or the evidence generations locally. Most of the equipment is clearly very one-shot equipment for this kind of running. And then we are missing the equipment in the generation of evidence. There is an unbalanced access to the AI and digital infrastructure, like the high-performance computing, data storage capacity. And there is an unequal access to the AI and healthcare work and digital workforce in the global south. It's very hard to retain talent in the global south, especially with the competition. But it is also in the north, it's becoming very challenging. And then the most important part, we often talk about sharing data. We rarely talk about sharing the output of data. How can we establish a model equity in sharing of the output, the AI models, the practice, the evidence, but also the knowledge and the know-how behind the generation of this output? It's really the time now to talk much more about collaborative data and sharing of the output or sharing of the knowledge rather than the sharing of the data and the collaborative of the knowledge. For that purpose, we need to establish a new model of trust. Think that it should cover the entire health data value chain from the early beginning of the research question, when it should not be biased either by the origin, the gender, or the context of the research question, data collection, still the scaling by practice. We need really to cover this entire health data value chain and to involve the data owners inside of that data value chain. Data owners should be also strongly associated with generated evidence, and we need to bring tribute to the data owners to the generated evidence. This is quite recurrent problems in AI. And we have seen a lot of debate about image analysis that has been done on the internet without the consent of people who are generating these pictures or images. And then how can we bring credit back to these people who have done the work about these pictures and images, but they have never been asked for consent to use their data as training data? And then data, we are strongly advocating that data should stay locally as long as possible if the analytics and the evidence collections can be done in federated, but even further confederated approach, where each of the data owner decide to jump in or jump out inside of the data pooling efforts. And then finally, in the model of trust, we are working towards, we would like to overcome the data stigma. We have seen that anonymization of data patients is an essential step for stigma. But what's about country anonymization? I've seen with the COVID-19 how countries got stigmatized regarding their findings and the evidence generated from their own data. And we end up by naming a couple of these variants of the COVID with these country names. So how can we ensure in this pooling of data that countries also are not stigmatized? For that purpose, we propose a bottom-up AI and data governance model rather than the top-down that we have today. We need to build a system of systems rather than one model that fits all that we have in the governance aspects, especially when it comes to the AI and data. Today, we are building some static systems, governance systems, and we are keep building the governance aspects and approach as we used to do prior to the digital revolution. I think that we need to bring a little bit more dynamicity inside of our thinking about the governance models to quickly overcome new research avenues. If we talk about missing data, if you talk about synthetic data for model training, these pieces are missing currently from the European governance models that is ruling the AI. How can we keep running after the technological evolution with a very static governance models? This is a big issue for us. Then we need to bring a multi-scale governance models for more contextualized and heterogeneity of rules and regulations. My colleagues underlined that very well earlier, talking about different rules in African countries, but also in European countries. And one single governance models will not be able to overcome all these heterogeneity. And then we need to bring a little bit more flexibility inside of our governance and rules to enable this better sharing. And often we need to bring people who we keep forgetting. We need to bring patients inside of the debate of the data sharing. data is coming from the patient. Patient is not a data source. Patient is a data owner, and patient should drive this transformation in a data sharing process, either in the global south or in the global north. At I-DAIR, I will present quickly what we are doing. We are building this approach in a neutral and trusted platform for enabling R&D in digital health and AI. And we are addressing these data and AI challenges on a daily basis. And we think that no single country today or research institution can solve these big issues or can build a roadmap towards the universal health coverage. And we need to act collectively, and we need to start sharing data in a very fair manner. For that purpose, we are building 4 steps implementing these 4 steps in the countries of activities where we are operating. Firstly, we are building infrastructure, pieces of hardware and software that are being deployed in research institutions. We are bringing the capacity by bringing some customized capacity development programs and inside of the institutions, helping them to make the move and shift from data analytics, classical data analytics, into the integration of AI inside of the research, and then building a community of researchers or community of practice around these kind of research projects. And finally, we are bringing all our partners inside of the governance aspects by building a new governance approach for all of these pieces of of our interventions. Thank you for listening.
Thank you very much, Dr. Mehdi Snene. And our last speaker is Pavel Sviboda.
Thank you very much for inviting me. And I have to say that when I first got the invitation to the panel, entitled as it is, How to Achieve a Global Health Data Space, I had a moment, a very brief moment of doubt, whether or not we are not over-promising and potentially under-delivering. But I very quickly concluded that it's the right level of ambition. The right level of ambition provided that we know very well what we are aiming at, and providing that we set the objectives very clearly. And in fact, when you look back at the WHO's global strategy on digital health 2020-25, something that Steve knows inside out, I'm sure, there are the ingredients of the plan for global health data space there, even though the term itself is not used. But what the global strategy speaks about is the objective to create an interoperable digital health ecosystem, and one that is meant to enable seamless and secure exchange of health data at different levels and for different purposes. So that, in essence, is what global health data space should aim at. And why is it needed? It's needed because of the tip of the iceberg problem, which continues to be very relevant and very painful, namely that only a fraction of health data is being put to any proper use. And when you look at the reasons for that, I think one good recent source is the TECHTAS report from February 2022. TECHTAS is a joint action in Europe towards the European health data space. And in February of this year, it published a report on the basis of a very careful analysis of the situation in a number of European countries. And on the right-hand side, in small print, but nevertheless, you can see a list of key barriers that were identified. And some of them you would have thought should not exist in a common legal space, such as the European Union. For example, the different interpretations of the General Data Protection Regulation, which is a regulation, so it should apply across the boards. It's the law of the land. It's not a directive which then has to be implemented. It's a regulation. But nevertheless, there are different ways of interpreting GDPR in the different countries. There are different ways of defining what anonymization means, what pseudonymization means. So there are these barriers which have been well evidenced. However, change is underway. And I think change is produced above everything else by the shift towards value and outcome-based healthcare. I think this is, and I'll come back to this, the single most powerful driver behind efforts at creating health data space. So the global strategy looks at both primary and secondary use of health data. When it speaks about the primary use of health data, it focuses on the enhancement of quality of processes and outcomes of health services. And again, I think the word outcomes is key because so much of the logic of our health systems is still not based on outcomes. And the moment it becomes based on outcomes, it's the moment when data gains an altogether different type of value. And that takes us directly to then health data spaces. Now, for secondary use of health data, this is primarily about building of a knowledge base and improving research effectiveness. And we could add one more horizontal aim, which is not in the global strategy, but which is extremely relevant, namely how to make data sets more representative. And here I show a graph used by the Davos Alzheimer's Collaborative, which indicates how much of the AD data sets, how big a share is coming from populations of primarily Western European origin. And that has to change. The Davos Alzheimer's Collaborative is an example of a project to create a global cohort that will be sufficiently diverse in order to enable targeted interventions. And that is one of the aims that we should definitely put at the forefront of efforts to build the global health data space. The global strategy actually defines very clearly a strategic objective. It's objective number 3, which relates to the issues that we are speaking about today, namely how to strengthen governance for digital health at different levels, global, national, and global, regional, and national. And why is this needed? It is needed in order to arrive at a definition of appropriate use of health data. I think we've seen already in today's panel that approaches to this differ, and we need to have a common and a commonly agreed definition of that use in order for health data to be seen as a public good. And then the strategic objective also speaks of some very tangible elements, such as a guideline on global interoperability standards. As a way of getting towards that objective, it postulates the use of commonly agreed use cases, which is very relevant. In Europe, we have the project of the European Health Data Space, which has just gotten underway. And there are 2 sides to it. One is legal, the other one is infrastructural. The legal dimension is meant to take 3 years and is meant to clear the way towards greater accessibility to health data. It is not meant to replace the General Data Protection Regulation. It will act on top of it in order to make data more easily accessible. The infrastructural dimension is meant to create the basis for data sharing, and I will come back to this. This is an important priority for the current political cycle, 2019-2024. It is very much based on this trust versus accessibility nexus, because the bulk of the legislation and the bulk of the legislative effort will be focused on creating greater trust among citizens in order for them to then be willing to share the data. And then, of course, there have to be the means technologically for the data sharing to take place. So the way this will function is that 15 mandatory categories of data are to be defined. Data access bodies will be set up to provide this access in a secure environment. And the novelty of the approach is that you will only needs a single data request to obtain as a researcher, for example, for secondary use of data. You will only have to have this one data request, and you will be able to receive all the data sets from across the different countries in one go. And there is now a pilot project that has just been launched, and eBrains, the research infrastructure I lead, is part of that pilot project. And this is to create the infrastructural basis for it. So what is the problem that this European health data space pilot aims to solve? Well, first of all, it's the fragmentation of data sets. That's the reality of the day in many scientific disciplines. Here I speak primarily of the secondary use of health data, which is what I work on. This is a challenge that leads to the various replicability and reproducibility crises that we deal with. And obstacles that needs to be overcome have to do with both the legal dimension that I already mentioned, the security dimension, ethics requirements, and cybersecurity on the other hand, data interoperability, and of course data quality as well. Not all data is equally valuable for research use. If a number of use cases has just been selected, this is very much in line with the World Health Organization approach for the strategic program, where the use of use cases was also postulated. And here in the European health data space, we now have 5 use cases. You have the list on the screen, and I think what the list shows is that there is also a certain agenda behind each of those. There are technological criteria, because the relevant data authorities needs to be willing to work on the use cases. There has to be sufficient interest on the research side, but also you can see from the list that there is also a broader logic for why these were selected. So from the surveillance of antimicrobial resistance all the way to comparing nationwide health trajectories. So I'm strongly convinced that this EHDS pilots can create a virtuous loop with the global health data space. And I've already noticed quite a number of similarities when Steve was talking about the data hub at WHO. So what the EHDS pilot is creating is a network of nodes. So that will be the underlying infrastructural basis. Key sectors, key actors in the secondary use of data, because this is what the pilot is focused on, are participating, including health data authorities, EU agencies, research infrastructures. And then the user journey is to be tested. This is extremely important. So from the very beginning until the very end, the pilot will work its way through the user journey. And researchers are at the end of the day to be able to send a query to metadata catalogs and receive the response back. And this infrastructure is meant to scale up as we go along. So on this basis, what are the essential elements of a health data space strategy? Well, in a nutshell, it has to be about a mix between interventions on the demand side of the equation and the supply side of the equation. And on the demand side, I believe that the shift to outcome-based healthcare is the single most powerful driver, let's say, because this is what will create the demand for the sharing of data in an altogether different scale. On the supply side, it is really about standards. It's about structuring of data, and data quality, but it's also about how to incentivize researchers, in the case of secondary use of data, to share. There's a lot of data hoarding going on at the moment, even in projects where you are supposed to share, even in projects funded by agencies which require sharing, there is still enormous amount of data hoarding. So what do you do? I mean, you can of course try to make sharing mandatory. This is what many funding organizations begin to do. but you can also incentivize data sharing by helping researchers to get and extract value from the data. And this is the business that we are in at the eBrain's research infrastructure. Namely, we aim to accompany the researcher in his or her journey in order to ensure that the utmost value is extracted from the data. So this takes us all the way to high-end analytics that needs to be provided. And I will take you very briefly through the eBrain's experience. So eBrain's is a research infrastructure, and what I mean by that, it's a collection of tools and services underpinned by high-performance computing and storage capacity. And what it offers in terms of value added is an attractive proposition to the researcher with respect to the fairness and high quality of data. We have unique data with a high degree of findability. This data is both human and machine readable. We use OpenMind's metadata schemas, which are more easily interpretable for the researcher. The curation of the data on eBrain's is assured by a team of experienced neuroscientists. So that takes care of the quality of data component. We can define access restrictions depending on what the given researcher wants to achieve, if it is for pre-publication or publication purposes that the paper is being written for. And we provide links to a range of different services and tools that help researchers to genuinely analyze the problem and extract value from data. So that's one side of the equation. The other side of the equation is that the research infrastructure has been developed by a scientific project called the Human Brain Project, and I have two hats. I lead both as the CEO of eBrains and DG of the Human Brain Project. And the logic, the rationale is such so as for the scientists and the developers, the compute and software engineers to be sitting together in order to develop the tools through the process of co-design. So that means that the tools are not abstract ones that are worked out with a presumed assumption of what will be needed. They are actually developed by scientists and engineers sitting side by side. I won't spend much time on this, but just to give you a glimpse of what eBrains offers, it's a range of services from data management through brain atlases, modeling and simulation, all the way to brain-inspired technologies and medical data analytics. One word about what it really produces, and produces something that we begin to term the eBrains knowledge loop. So you take the data that you can access, you model and simulate to create virtual data, and then you provide model validation tools, and you apply knowledge inference tools in order to produce the result. So that's the knowledge loop, which really aims to get as much value out of the data as possible. And of course, as Petra mentioned in the introduction, the sensitive data challenge is unique in its own category, and we are ourselves equipping eBrains with the technology to be able to work with sensitive data in the GDPR compliant fashion, and that's the health data cloud. So I will finish by saying a few words about what I would see as some of the immediate steps towards the global health data space. I believe these are all steps that could be relatively easily undertaken, and I would start with the pledge on interoperability, because we spend a lot of time discussing interoperability, but it would be high time to start doing it. Research infrastructures such as ours are open to scaling up that project of creating a global interoperable space. The second component could be the global data quality framework. We have such a global data quality framework in Europe. It helps the regulators to approve various procedures coming from also industry. And it would be extremely helpful if a global data quality framework if the data quality framework could be established at the global level. And finally, drawing on the experience of the European health data space and the underlying logic for it, it's really about trust and accessibility, how you create a nexus between the two, and that has to be helped by establishing a number of building blocks in legal, operational, technical, ethical, and societal aspects. So I believe that we are indeed on the path towards this global health data space, but we need to undertake some joint commitments in order to get there. And these are some of the ones I would see as the most pressing. Thank you so much.
Thank you so much, Pavel Svoboda, for this excellent final speech. And we have now the opportunity to take questions from the audience here, but also from the online audience. And while the microphone is passed to the first person who questions, I will ask a first question to our panelists. So this was the first sign I saw. But my first question is pointed to Steve. So I was really listening with high interest about the endeavor of the Global Health Data Hub. And I would like to hear your opinion. How does the World Health Organization achieve this legal interoperability? I think this is a big challenge, also given the different ethical and moral frameworks in different regions of the world. So is there already a starting point? What is the approach at the World Health Organization?
Yeah, thank you. It's a good question. So we can look at it from two approaches. One is the World Health Organization has data principles, and those principles we hope are universal, and they don't really have a regional component. But we're acutely aware of the challenge, and I think many speakers have alluded to it, and we could wrap it up as data colonialism. It's how to make sure that people in the regions have access to their own data, and that's really driving what we're trying to do. So for the statistics part, it's relatively straightforward. We ingest the data, we aggregate them, we clean them, and we make them available to everybody at the same time. The bigger challenge are the micro data sets, whether they're human data or non-human data. They're all sensitive in one way or another, and it's how to make those data available. How people access those data will depend on the data sets, but a big challenge or a big discussion we're having at the moment is the broad model. Do we bring the data to the researcher, or do we bring the researcher to the data? And that has big implications for us. In particular, if we bring the researcher to the data and they do their analysis on our platform, then we incur all the CPU costs. And we've learned from experience that poor code can generate massive costs very, very quickly. So these are some of the issues that we're trying to examine. But the broad principle is how to make the data available. Now, obviously, there's different legal jurisdictions. What we see in Europe is GDPR, in a way, because it's first mover, it's essentially imposed itself on the rest of the world, because most other entities deal with the European Union in one way or another. So we see a lot of entities, including WHO, are having to adopt a lot of GDPR kind of in a secondary way. So I guess that's the model that we're using for the moment, but we see across the world that there's different models being discussed, being developed, and that's something we're alert to. So in time, if, for example, the African Union, that they're looking at kind of data protection, if they are to develop something different, then we'll have to take that on board. So it's a movable feast at the moment. Thank you.
Thank you so much, Steve. And now we get the first question from the audience. Please also tell us whom you ask in the panel.
Good morning. First of all, to thank to a brilliant panel of persons that address real issues and real day-to-day problems. I address and I speak mainly for Mehdi because it was inspiring. It's very pragmatic. It's from the south, he knows the problems. Because the first thing that we should be discussing, and data is important about that, it's not poverty, it's not the problems, is that we need to create wealth. We should shift between being all the time speaking about the problem, about poverty, but we need to shift to health. And in the south, we need that. I came from Angola, just to finish. So the second thing is that information, I think that is clear for everybody that are here. It's a key issue for the universal health care. So the poor countries need a lot more information and need a lot more innovation than Europe, because we need to we need to have bigger steps in a shorter time. That is it's important for democracy and for transparency. Without that, it will be impossible to, in 10 years, we not being speaking about the same things. And that leaves us to another situation that we need to speak more about ecosystems instead of systems. We are always speaking about systems, bringing a system of company A or company B or something. We need to speak about processes, about data sets, and about ecosystems. And finally, monetization and the private sector being involved. It's not a crime. The money comes from somewhere, and the private sector in the poor countries need to be a lot more involved because they are more quick, they are more innovative, and it's not the opposite. It's not growing the government, it's not taking more things to the government, it's to involve the academia and the private sector a little more. I don't know if Mehdi agree with me, but that is the vision that in Angola we are trying. We are from the private sector. We work a lot with several state departments, and the ones that have more success is the one that shorten the size of it and work a lot more with the private sector. Thank you.
Thank you very much. And I give the word to Mehdi. Maybe you want to comment?
Thanks so much for your appreciation of the presentation. And then I can't agree more when it comes to the wealth. And it's very close to the health. I think that these two should go together, and then it's much more about innovation and economic value creation in local systems, in local ecosystems, and the creation of the system of systems that I may call it, which is very complex. We are looking at the health innovation data in health as a single one shot, which is not the case. It's a much more complex, and there is a lot of stakeholders inside of the balance, and we need to bring all these stakeholders together around the table and to discuss it from the early beginning of the current issues that we are facing in the global south or in the global north to the wealth creation, the economic value of the solutions that are being brought to the ground. So it's a complete value chain, and we should not simply focus on the data. We should not really focus on the entire value chain of the data transformation, digital transformation of the healthcare system, and then the output. It's from economic point of view, but also from patient outcomes, and then for the increase of the health and well-being in the populations. This is also an essential step. The funding is quite challenging problems when it comes to the building this kind of distributed research infrastructure across large multilateral countries in the global south. But we've seen that countries today are willing to invest in these research infrastructures and bringing more own capabilities inside of building their research infrastructure, getting some connectivity with us or getting some connections, helping them in building the consortiums. But most of the countries today
especially after the COVID-19 crisis, are showing a great interest in building these kind of collaborative research infrastructure for the entire ecosystem and for changing the game inside of the Global South, at least when it comes to the data and healthcare. Thank you for your generous comment regarding the presentation. I much appreciate.
Thank you very much, Mehdi. And we have the next question. You would like to add? Sure.
That also Steve mentioned the data from J&J, and I wanted to clarify that in fact the data stays local. The data belongs to the countries where we are actually helping to develop those types of solutions. The data does not belong to J&J. We are just accessing the data, and we are blinded to the actually primary data. Even in the data management programs, we are actually purview to just that aggregated data that we can actually provide in order to foster the operations. Some of the platforms are open access. So for instance, My Hub, and even the Vaccinate is part of our Health for Humanity goals. It is actually, we've partnered with the WHO in the Solidarity trial, and we are offering, because it's in fact agnostic to the type of vaccines or platform, it's just, you know, an integrated technology. So you are absolutely right. We have to work with the communities, and we have to generate knowledge that can be then shared with that community.
Thank you very much for this addition, Roxandra. We have another question from the audience, and then we have one more question from the online audience that I would like to read after your question.
Yeah, thank you. My name is Jean-Philippe Pampana. I'm a research director at INSERM in France in the field of cardiovascular disease, and also I have a chair on global health at the university. And following on what has been just said here, I would really like to thank you, Dr. Sneen, for your presentation, and in a way to be the voice of the Global South, which was a bit forgotten in the presentation, maybe. And Mike, I really feel agree with you when you talk about the fact that for this digital transformation, we need to take into account the contextual local context. And so to my view, it's also about co-construction. So my question is to you, and also to Dr. Draghi-Akli, sorry, I don't see well your name, about co-construction. Do you have some, concretely speaking, how do you, in the field of digital transformation, how do you co-construct this kind of project with the community or with the country? How does it work in practice? Thank you for your answers.
Thank you for the question.
Thank you so much. So let me start by some historical vision of I-DAIR. It started 3 years ago with Ambassador Amandeep Gill, and he got inspired from CERN at that time to build a CERN-like digital health and AI infrastructure and collaborative, but fully distributed CERN. So this is, we keep presenting us as a distributed CERN for digital health and AI. And what we are doing in practice in a very pragmatic way is we are looking on common burden across different countries that we can bring together around the table, and we believe that a digital or AI solutions can reduce this burden, or can bring quick solutions and quick outputs and measurable outcome on the patient life or on the increase of healthcare and well-being. So very basic process. We talk to countries, we talk to research institutions, we look into the portfolio of research institutions, mostly the research institutions that are not yet dealing with digital health and AI research. So we are really looking towards leaving no one behind. So we don't keep the same scheme of picking big players in AI and digital health. We are really looking for those who are willing to bring the AI and digital health in their space, but they do not have access to it yet. And then it's very easy later, once we got the first consortiums of research institutions, public health institutions, healthcare providers from different countries, it's very organic way of building the requirement, gathering the requirement, and building commonly a common research pathway towards common solutions that will be shared among the consortium partners. What we do is that the consortium is not a static consortium. We often are very open to growing consortiums or dynamic or living consortiums. So we keep adding more partners while we are on the pathway of the development of these solutions, either in digital health or in the AI, either by bringing more data or bringing more requirements or bringing more patients. In all cases, most of our consortiums need to bring a couple of stakeholders, public health policymakers, patient representation, researchers and practitioners. So once we have these four kind of stakeholders around the table, it's very easy to overcome different difficulties that are arising here and there, because we have some background, some experience, and also some people who can quickly tackle these kind of gaps and issues because they are already on the ground, they are already there and know how to deal with that.
Thank you very much, Mehdi. And we have now time for only one more question from the online audience. And this is a question from Arthur Olisch, and it goes to Pavel Sviboda. How to encourage the scientific community and private companies to share data by introducing a new legislative framework that, for example, imposes a requirement to share data that is important for the public good, changing the work culture, rules against data hoarding, what else?
Yes, thank you so much for the question. I think it needs to come from both sides, and they were indicated in the question itself. Namely, funding agencies need to encourage sharing because data is public good. I think we framed it in the right fashion at the beginning of this panel and throughout it. And if that's the case, then the sharing needs to be mandated. If public resources are spent on research projects, then sharing should be mandatory. I think it's as simple as that. And this would actually open altogether different types of opportunities. And this is happening. It's not happening in sort of super rapid space, also because funding agencies are aware of the fact that the grant needs to be prepared. So it cannot happen literally overnight. There has to be a certain period. So, for example, the Swedish funding agency set the 2026 objective when this will become mandatory. So there is a certain period for preparation, and I think that's the right approach. However, the guidance and leadership here is very much needed. So that's one part of the equation. And the other part of the equation is where we are active as research infrastructures, namely how to make sure that researchers can get more out of the data so that they do it more out of their own self-interest as well. Namely, they would like to extract more value. They would like to get to the results of the project, and they would understand that sharing is part of that phenomenon. So creating better analytical tools, having a better offering for researchers in terms of the tools and services that they need is also part of this equation. But I think leadership has to come from funding agencies, and it's about time to make sharing the part of our culture of doing research.
Thank you so much, Pavel. And I'm afraid our panel comes to an end now. Let's thank again the brilliant speakers. And thanks so much also to everyone in the audience for joining us and for also getting involved in the discussion. Have a great day. Bye-bye.